Hello, my name is Christine Duncan from Dana-Farber Cancer Institute. Today I'm going to be talking with you about veno-occlusive disease and the differences between children and adult patients. And while there are many things that are similar between these two populations, there are some distinct differences that we'll discuss. In general, the incidence of veno-occlusive disease is reported as between 10 and 60% for patients who receive allogeneic stem cell transplant with myeloablative conditioning, and 5 to 30% in patients who receive autologous conditioning. However, the incidence is greater in pediatrics, so the overall incidence reported in the adult population is 10%. The overall incidence in the pediatric patient population is approximately double that at 20%, and in some high-risk patients as great as 60%. There are multiple different risk factors that overlap the pediatric and the adult patient. Some of those will be briefly reviewed here, but I'll be focusing mostly on those that are unique to pediatrics. And so in recent years, we've been thinking about the pre-transplant therapy and how that affects patients. In the hematologic malignancy population recently, we're thinking specifically about directed antibody therapy, such as gemtuzumab and inotuzumab, increasing the risk. We also think about transplant-related risk factors such as myeloablative conditioning regimens. In general, myeloablative conditioning regimens are used more frequently in children than in adult patients, including the backbone of many regimens, including total body radiation for children with certain hematologic malignancies and some non-malignant disorders, as well as busulfan. In pediatrics, though, there is a specific group of patients, particularly many of those with non-malignant disorders, that are at heightened risk for veno-occlusive disease. These are often rare genetic disorders that are not frequently transplanted in the adult setting. There are specific diseases in the pediatric population, particularly non-malignant diseases, that have an increased risk of VOD. In the malignant realm, we think of children with neuroblastoma as having heightened risk of VOD. This is often due to the pre-transplant therapy that they receive. In addition, there are children who have solid tumors who do not progress to stem cell transplant who experience VOD, often as a result of treatment with the medication dactinomycin. Other patients, particularly those with certain immune deficiencies or immune dysregulation syndromes, including hemophagocytic lymphohistiocytosis, X-linked lymphoproliferative disease, and others, have a heightened risk of VOD and often severe VOD. The rare pediatric disease osteopetrosis, which is a disease of bone metabolism, has in some reports almost as high as a 60% risk of osteopetrosis. And then there are other diseases such as thalassemia and sickle cell disease that we are uncertain of that risk of VOD, though as these are often diseases that experience endothelial injury, it is likely that those patients have different risk from other patients of VOD. And we are still learning about genetic factors that may predispose children to VOD, and this is an area of intense medical research. As you likely know, there are two primary diagnostic criteria that have been used for many years in the diagnosis of VOD. These are the modified Seattle and the Baltimore criteria. While these are extremely useful tools, they're not necessarily always adequate for the diagnosis of VOD in children. So the modified Seattle criteria requires that in the first 20 days after the stem cell transplant, the presence of two of the following: a bilirubin greater than 2 milligrams per deciliter, hepatomegaly or pain in the right upper quadrant, or weight gains greater than 2% of the basal or baseline weight. In the Baltimore criteria, this is diagnosed in the first 21 days after transplant with the presence of bilirubin greater than 2 and 2 or more of the following: either painful hepatomegaly, ascites, or weight gain greater than 5% of the basal weight. Some of the challenges with diagnosing children along these criteria are that there is a greater incidence of anapteric VOD in children, and so VOD where you do not develop high bilirubin levels. And so this can develop in as much as a third of pediatric patients with VOD and would make it very difficult to fulfill either the modified Seattle or the Baltimore criteria. In addition, there's a greater incidence of late VOD, so VOD occurring after day 21 in children. And so those children who have late VOD wouldn't meet these criteria as well. Additionally, a 2% or even a 5% weight gain may be trivial in a young child or may be attributable to simple things as hydration. So for example, a 2% weight gain in a 70 kilogram or 154 pound adult is a 1.4 kilogram weight gain or 3.1 pounds, which may be clinically significant. In a 10 kilogram or 22 pound toddler, this is 0.2 kilograms or 0.64 pounds, which is a relatively small amount and may make it difficult to identify that as a significant problem. And finally, hepatomegaly may be baseline finding in some diseases, so it may be important to discuss the change from baseline rather than absolute finding of ascites or hepatomegaly. Based on some of these and other concerns, the European Bone Marrow Transplant Group have proposed pediatric-specific guidelines. And so in these guidelines, the patient need to have 2 or more of the following without limitation or restriction on the time of diagnosis from transplant. So unexplained consumptive or transfusion refractory thrombocytopenia, and otherwise unexplained weight gain on 3 consecutive days despite the use of diuretics, or a weight gain greater than 5% of the patient's baseline, hepatomegaly greater than the patient's baseline, ascites greater than the baseline, or rising bilirubin from the baseline value on 3 consecutive days, or bilirubin greater than or equal to 2 within 72 hours. These guidelines have not yet been uniformly accepted and are being studied, but it is important to think about the nuances and the highlights from these guidelines and how they structure the differences between pediatric and adult veno-occlusive disease. While the management of pediatric and adult VOD is often quite similar, there are some nuances that are different. And so the similar principles apply in that everyone needs to have meticulous fluid management, awareness in pediatrics, however, that even a small amount of fluid or weight gain can cause a significant impact in the respiratory status, including pulmonary edema, or the renal status, where even small amounts of weight gain can contribute to abdominal compartment syndrome with potential compromise of the renal output. In general, it's felt that peritoneal drains and chest tubes are placed perhaps more readily in pediatric patients, perhaps in the very small patients, due to the limited abdominal compartment and thoracic space, and how the increase in the abdominal size can compromise the breathing status. Defibrotide therapy, which is discussed in multiple modules, has been demonstrated to be effective as prophylaxis and treatment in children. However, the optimal timing is uncertain. These are ongoing studies. The defibrotide experience has generally been more successful in pediatric patients than adults, though effect has been shown in both population groups. A principle that's important to both adult and pediatrics is obviously the consultation and partnership with pharmacists. There are multiple drug interactions and alterations in drug metabolism and clearance that can play important roles in the management of a child with VOD. Specifically, patients may not clear their sedating medications or pain medications more readily, and this can lead to confusion regarding the neurologic status. This can be difficult to assess neurologic status in the very young child, and we hope to have this very clear as an altered mental status has significance in children with VOD. In addition, patients may have decreased clearance of cyclosporin or other calcineurin inhibitors and have high levels, which can cause renal compromise and other issues. So it's very important to discuss these issues with your pharmacist. And finally, that pharmacist and the others are the important parts of a multidisciplinary team. In pediatrics, it's very important to involve the parents and the family as well as the child in this multidisciplinary team, as some of the signs or symptoms may be subtle, and your first clues to the changes in a patient may come from the parents or nursing reports. In regard to the outcome in pediatric versus adult patients, multiple studies have demonstrated superior VOD resolution and survival in children compared to adult patients. On the right-hand side of this slide is a figure coming from a publication in 2016 showing the survival in pediatric patients on the top line compared to adult patients, and this comes from a large compassionate use of defibrotide program. Additionally, we see that VOD resolution and survival is superior in patients who receive defibrotide compared to those receiving the best supportive care alone. However, there still remains work to be done. There's up to a 4-fold increase in the mortality at day 100 for pediatric patients who develop VOD compared to those who do not. So in summary, there are many similarities between children and adults at risk for and diagnosed with VOD or SOS. There are unique features and factors for VOD in children, particularly related to their underlying disease for which the child is receiving the stem cell transplant. Diagnostic criteria need to acknowledge and account for these features of VOD presentation specific to children. And finally, survival is a very realistic goal for pediatric patients with VOD and SOS. And to get to that point, management must be thoughtfully meticulous. Thank you very much for joining and listening to this discussion.